Thank you, Ben, Joel, for putting this together. It's an amazing course, and very honored to be here and be able to share some time with you guys. I'm always the complicated one with keynotes, so bear with me until they connect the presentation. I'm glad that we did this in Chicago this time of the year, not in February. I promise it's not the greatest.
Dr. Body, while we're getting everything loaded up, I'm just going to keep picking on you. What would you say is your, other than, center edge angle, you sort of have someone you suspect for being quote unquote borderline. What would you say is your next most important radiographic parameter? Hmm. I thought that was really cool when it came out. A little worried about the abduction of the leg on the X-ray. I think you got to take that into account when you're assessing it. For
Great
me,
point.
it's the anterior wall index. I wasn't routinely measuring that when I first started, and I think I got bit a couple times. There was someone I might have given a PAO, and I looked more closely at that.
That's a great point. Yeah, that's a very, very important measure as well.
Sanjeev, what do you look at physical exam-wise that makes you concerned, right? Before you look at the x-rays and you're examining the patient, what makes you concerned that that patient may not be a candidate for hyperarthroscopy?
Yeah, I mean, joint laxity, I think, is really, generalized joint laxity, I think, is a really key thing. Females as well. I think those two factors are probably, puts my antenna up.
How about internal rotation? Somebody that you put prone and they go to 90 degrees, what do you tell them? And is that a patient that you always get a CT scan on, or how do you manage that patient?
Yeah, no, I think that's a great point. I think we lean towards getting a CT scan on them and measuring their femoral version. I think in that setting also, like Ben mentioned, the anterior wall index is a very important measurement there as well. So yeah, those are the ones where I certainly would want to get a CT and have some of our other colleagues take a look.
Sorry, the controller is not working. Would you mind passing to the next slide? Next slide. I think we'll do it this way. So these are the main three things that I want to discuss today. When to do hyperarthroscopy in classic dysplasia. Please, anybody from the anchor group, don't get upset yet. Borderline dysplasia, and then alignment with the femoral version and fear index. Let's go to the next one. Still doesn't. Unless you guys did it. So classic dysplasia, of course, this is not the one that we want to emphasize hyperarthroscopy for, lead to arthritis and increased THA. Pain and dysfunction at a young age, very, very more prevalent in female patients. Next slide, please. So the incidence of labrum tear, and the next slide, in cartilage tear is extremely high, over the 90% for these patients that, hey, even when they have 18 or 17 degrees, they can have a very high incidence of cartilage and labrum tearing. You can go to the next slide. Will this work at all or no? No, it's not. This is from the burn group, and you can see how dysplasia actually loads the cartilage. It's dramatically more on the top. So between that 11 to 1 o'clock, and the normal load is way more better or overly distributed throughout the cartilage. But you can see a dysplasia patient, that those patients load the cartilage very, very high. And this is some work from Cecilia as well that showed very, very similar findings. Next slide, please. So when you look at the outcomes, this is a key study by Chris Larson and Ashish Beatty. Can you keep going until you develop the full slide? So 40% failure rate when you do just hyperarthroscopy in this group. So this is the group that you probably don't want to do a hyperarthroscopy in isolation by any means. Next slide, please. This is another study by Ashish, 36 hips, 13 with femoral head migration, 14 had accelerated osteoarthritis after hip arthroscopy. So again, this is not the patient population that you want to do this in isolation. Next slide. So indications for hip arthroscopy, keep going, please. There's no role in isolation of classic dysplasia unless you do it pre or post osteotomy to address the cartilage or the labrum. There's some data from the Yanko group that says also that you can potentially avoid this in this patient population and the outcomes are the same. But if you're concerned about any cartilage or any labrum pathology, you can do this pre or post the PAO. Next slide. How about PAO alone? You can keep going, please. So outcomes, this is a study by Paul Boleg. Keep going, please. Just go through the full slide. So multi-center, 97 PAOs, no significant difference in functional outcomes. They measure IHOT, HOS, and PROMIS. Keep going, please. Only IHOT had significant differences. So PAO alone can be a pretty beneficial procedure for this patient population. Keep going. For borderline dysplasia, this is the group that Sanjeev was talking about, those between 18 or 20 and 25. Why to do hip arthroscopy? Keep going, because you can achieve MCID in a majority of them, and Ben has published on this as well, 86% in this series. Keep going, please. In borderline dysplasia, good outcomes with hip arthroscopy or PAO have been reported. The role of the fear index and the femoral version is what I take in my practice to try to understand which patients should undergo potentially a hip arthroscopy and which are the ones that I'm going to send to Joe Williams. Keep going, please. So if you have a lateral converging fear index, then I know that that's probably more stable, and that's the one that I may do a scope in conjunction with not having anterior wall deficiency, or if they don't have an increased anteversion. But again, we work very closely with Joel and try to understand any patients that have borderline dysplasia. I usually send to him for evaluation as well. And if they have lateral diverging fear, that's a more unstable hip. So those are the ones that I'm thinking more, again, with internal rotation, some physical exam findings, and potentially doing a PAO as well. Next one. In regards to the femoral version, the lower the femoral version, the less concerned that I am. So the more the anteversion, mostly the combined index of anteversion, those are the ones that I fear the most that may be potentially unstable, and those are the ones that I may potentially think more about a PAO. Keep going, please. This is a new meta-analysis. We looked at all the studies that were published, 6 studies, level of evidence between 1 to 3, 5 to 10-year outcomes after FAI, just with scope, 3 with scope. Next slide, please. This is the outcomes where they found, keep going, that the controls versus the borderline dysplastics, there was no significant differences in those carefully selected patients. Next slide, please. Complications between controls, so people that had over 25 degrees of lateral center edge angle were not deemed to be dysplastic, was pretty similar, 12 versus 15%, keep going. And this is again over 6 studies that were published in the literature, and 4 versus 3.7%. Next slide. So no significant differences there. What we found out is indications are absolutely the key. If you find anything, as Sanjeev was saying, from a clinical perspective and or radiological that leads to any instability, you should probably address it. If you don't feel there's anything there, it's mainly an impingement problem, those are the ones that you can potentially treat with just a scope and can do very well. You can expect good outcomes with low complications and improved PROs. Next slide, please. How about femoral version? So we know now, this is a study by Vikas that I find very interesting, because when you have a very low version, there's very low chance of having instability, at least from an anterior perspective. And the higher the anteversion, not just in the femur, but when it's combined also with the acetabular side, it can make it a real bad problem. Next slide, please. So this is 43 articles. Keep going so you can do the whole slide, please. 31% incidence of acetabular version abnormalities, almost 50% of femoral. So it's very, very high prevalence of these issues, even in hips that we treat for with just a hip arthroscopy. So we have to be more vigilant of this. Next slide, please. So if you see this, high internal rotation in a patient, you put them prone and they have more than 30, 45 degrees, those are the ones that start to suspect that they might have some version problems, and those are the ones that you want to study more with a version study from an imaging perspective. Next slide, please. So this is a slide from Robbie, which I find very interesting because you can see patients with a normal progression here, like you see on on the left, and then keep going. On the right, you're going to see some inward pointing of the foot, as you can see there. So that's a patient you need to be concerned about some version abnormality as well, and consider for not just the hip arthroscopy. Keep going, please. So outcomes of this combined borderline acetabular dysplasia and increased femoral anteversion. Keep going. You can see that only around 60% of these people did well. So those are the ones that you don't want to do a hip arthroscopy alone again. Please go over the full slide. So they looked at MCID, SCB, and PASS. And keep going, please. Keep going. So revision of arthro versus DHA when you had a version of more than 20. Keep going. And borderline and no borderline, you can see that version can be impactful, but in the setting mostly of borderline dysplasia as well. Keep going to the next slide, please. Fear index, as Sanjeev was saying, this measures to some extent hip instability as well. More than 5 is considered unstable. Keep going. I've learned this from Ira Saltz in my rotation a couple of 5, 6 years ago, and he always looked at this very carefully, along with the anterior wall deficiency and others. Keep going. Please go through the full slide each time. So that can predict instability. It's not very sensitive, so you can't use this in isolation. You need other factors such as the femoral version and some other clinical factors as well. Keep going, please. Alone is not able to fully predict, again. Keep going. So fear of more than 3 degrees for predicting treatment with PAO can be very good. So if you have instability in treatment with a PAO, those patients can do extremely well. Keep going, please. And that correlates with the femoral version as well. So this is fear more than 2 with anterior wall deficiency. Keep going. If you do arthroscopy, only probably half of those patients will do well. So this is the one that, again, you want to be very careful about. Keep going, please. So indications for hip arthroscopy, and this is probably the most important slide, in borderline dysplastic patients is the one that you do not suspect any instability. They have a negative fear index, no significant combined anteversion. Physical exam is compatible with impingement versus instability. A high-level athlete that requires extreme range of motion, such as a dancer. Not a PAO candidate because they might have degenerative disease and may not make it a candidate for PAO anymore, or pre and post osteotomy as well, if you decide to go that route. Next slide. I think we're going to go over some cases now. Case number 1, keep going, please. Let's go through this relatively fast. So 31-year-old, the hip feels like it comes out of the socket. Patients say that they have that sensation of instability, so that's the one that you have to trust the patient's feelings, right? So if they're telling you that the hip is probably coming out of the socket, you have to trust that that is the case. Has failed a trial of conservative treatment. Keep going, please. Physical exam, they have a relatively normal physical exam, internal rotation of 45, positive failure and favor. Keep going. There's some hyperlaxity, a Baton score of 7 out of 9. That's the one that I started to get concerned about, as Sanjeev was saying. Those hyperlax patients never do very well with just a soft tissue procedure. Keep going. So the fear index is mildly negative here. There's a little bit of anterior wall deficiency, as you can see here. Keep going, please. We're going to see the CT scan, the MRI first. It shows a labral tear, but in all honesty, probably the labral tear is not the majority of the problem here. Keep going. And this is a 3D rendering, basically, of the CT scan that shows that there's some impingement, but also that there's, keep going, please, that there's some anterior wall deficiency. Keep going. So this is the patient that when you do a hip arthroscopy, keep going, please, and you see this femoral cartilage damage at the bottom of the hip. If you see that, that is a sign, pathognomonic sign of instability. So when I see that in arthroscopy, I go out of the room and I call Joe Williams and I'm telling him that this patient is going to him next week, right? So that's the one that you want to treat the intraarticular pathology, keep going, and then send back for a PAO. So this is courtesy of Rob Westerman as well. Next paragraph. Next paragraph. Next. Too much dictation. Case number 2. So this is the one that 21-year-old male, collegiate softball player, persistent right hip pain, non-contact injury, had 2 prior hip arthroscopies with liver repair in 2018 and 2020. Next slide. Physical exam, range of motion is relatively normal, but abduction is 55 degrees, a pretty painful hip, positive failure, well-healed surgical scars. Next slide. This is X-ray, so 6 degrees of Tony's angles, 24 of center edge. Next slide, please. And on the MRI, we see this, which is not very uncommon. Can you play the video, please, for me? You will see this a massive capsular deficiency, but the capsule is not really completely gone. The capsule is basically just never repaired, right? So it's hanging almost at the mid-neck, and there's not a lot of proximal capsule. So this is a patient that we know has also a soft tissue problem. Next slide, please. So you can see when you pull traction in this patient how unstable this hip will be. Please do that. Play the video for me. So that's how unstable that patient is, right? So there is a component for soft tissue instability as well. This is the capsule. You can see how much it's been retracted since the previous procedure, and this is one that you can potentially repair. So we developed this technique by taking some of the indirect head of the rectus and using that as the proximal leaflet of the capsule. And you can see the capsule on the other side looks actually pretty good. So once you detach some of the distal portion of that indirect head of the rectus, you can actually use that to close the capsule very nicely. And you will see that here, we're passing sutures from the rectus here and through the capsule, and that's the final outcome. And you will see when we start to pull on this right after surgery, all the instability is pretty much gone. So you can actually restore this when it's a soft tissue problem and you don't suspect that there's a bony abnormality. Next slide, please. Next slide. So in conclusions, classic dysplasia, you should never be doing an arthroscopy alone, maybe before or after a PAO for any particular pathology. Borderline dysplasia, in my practice, I only do an isolated arthroscopy when I'm fairly confident, and we've seen with my partner here that this is not a candidate for a PAO, so if they have high anteversion or a positive fear index, those are the ones that I fear that will do pretty poorly. If they have ligamentous laxity, also, regardless of what the bony abnormality looks like, if they fail the scope, I also think about a PAO very heavily. And then alignment and femoral version, as we know, get a PAO in every single case. Thank you.
Well, I got you. For borderline patients, you know, we have all these acetabular metrics, but one thing I look at is just, you know, do they have a cam deformity here? Because if they're borderline dysplastic and have hip pain without a cam, it's hard for me to convince, you know, it's hard to convince myself that impingement is really driving the problem. Do you think there's a role for arthroscopy there, or do you think they should just get, you know, go get a PAO?
I think there's so many confounding variables, man, that it makes it really difficult sometimes in those borderline patients, right? Because you can always trick yourself to see a cam, and a cam, it's you know, when you talk about alpha angle, that's probably one of the worst measures I've ever seen in orthopedics, because it talks about a 2D measurement of one bone in a two-bone problem, right? So it's such a dynamic problem that it's hard to see on a 2D view. So I rely a lot in my physical exam. So in what the patient says, patients usually say, you know, I feel, you know, like the hip moves inside. So that then it tells me more about instability. And if somebody has increased internal rotation, if they are somewhat lax, right, those, I have a hard time believing that the cam or the impingement is the main problem. Now, if they don't have any instability, they have normal range of motion, they have borderline dysplasia, a male that plays, I don't know, hockey, for example, that's the one that I probably lean more about a potential impingement problem. But I think it's a hard problem to decipher, right? And that's why I think when you have this problem, you have to load the boat. That's one of my mentors used to tell me, is just bring your partners in, that may see it from the other side. When you have a mallet in your hand, everything looks like a nail, right? So you sure have to rely on, you know, I tell patients, you know, this is the time to take a step back and, you know, have a couple more opinions to make sure that we're doing the right thing for you.
Very good. And then we're going to go next to Dr. Neppel, and then we can have questions at the end.